Patient we're about to operate on has two herniated discs, L3-4, L4-5, and she has facet joint pain off to the left side at L4-5, L5-S1. So disc pain 3-4-4-5, facet joint pain L4-5, L5-S1. We figured all that out ahead of time during my examination of this patient in the clinic. You need to do a physical exam to know where pain comes from. And then we combine that information with their MRI. So we're going to get started by doing a Deuk laser disc repair to fix the two herniated discs, one at L3-4, one at L4-5. And then we're going to do the Deuk plasma rhizotomy to treat the facet joints on the left side at L4-5, L5-S1. So bear with us as we get started. We're going to start by numbing up the skin. Just lay still, giving you a little bit of numbing medicine. Well, just like at the dentist, nobody likes getting that needle stuck in their mouth to numb up their teeth. But, you know, it's a bit uncomfortable. But after a few minutes, it starts to feel a whole lot better. You're doing great. Thank you, doctor. By the way, our last patient we just finished, he's almost ready to go home. He's doing fantastic, smiling. And I'm going to go check on him when I'm done here and then get him home. All right, let's go ahead and start by showing our audience what the reason is that people with herniated discs end up getting back pain from.
Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com.
Okay, welcome back. So the first step in this surgery, the Deuk laser disc repair, is to guide a needle from the outside world where we are down to the disc herniation. And that's what we're trying to do right now. Shot, lateral. Now to do that, we use a navigational process using an X-ray machine called a fluoroscope. And that is a machine that I have Jordan, who's running the machine, shot. And when I say shot, I'm asking him to take a picture with that machine. It's like, we call it a shot. And every doctor calls it different things, but that's what we call it here at Deuk Spine. Shot. Now our patient has two herniated discs that I believe are the source of her back pain, along with her facet joints. Shot. And AP. And those herniated discs are at L4-5, which is right where the needle is aiming, and L3-4. So I need to navigate to those two discs. I'm getting closer. You can see the facet joint right at the tip of the needle is hypertrophied. It's enlarged. Go ahead and show them that facet joint. We're going to show you right now on that view of the X-ray the enlarged facet joint. Show them that. There you go. Yeah, it looks like a semicircle right there. Yep, it looks like kind of a balloon, and we're about to pop it. That balloon is actually bone, and it's really the facet joint at L4-5. That's part of the reason she's having so much pain, is that that joint is just enlarged, much bigger than it should be, and it's full of arthritis. You're doing great. Lay still, Sean. So not only are we fixing her herniated disc, we're also fixing that facet joint. Any pain? How is she?
Good.
Reliable?
Yep.
All right. Looking good so far. I can feel the herniation. You could see the needle in the foramen right against the herniation. AP? You're doing great. Lay still. She's not moving or anything. I'm very pleased. Are you happy with her? Perfect. Let's go back to the lateral view. So you can see I snuck around that enlarged facet joint, and I'm now anterior in front of it. Yeah, I might as well give her a little more numbing medicine. Just relax. I'm going to give you a little more numbing medicine. So now that I know where our entry point's going to be for both needles, I'm going to numb that area. I'm not ready yet. I want to get into the disc first. Shot. All right, we're right up against the herniation. Once again, I can feel it. We're going in. We are inside the L4-5 disc with the needle. So it's perfect. We went through the tear and the herniation. You can't do better than that, folks. See, other surgeons have to tear out your spine in order to get down to the herniation. But we're not doing that. We're doing it all through a natural hole that's already there. Let's go ahead and show our audience a video. Which one have you shown? Just the why did disc cause pain?
Yeah.
Let's show our audience a Deuk laser disc repair video that shows them how we fix disc pain from a painful disc. Shot?
Disc herniations are a common cause of chronic back pain. The inflamed annular tear causes back pain. Inflammation of the nerve roots causes leg pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com.
Shot? All right, welcome back, folks. We are just about ready to get started. Shot? I just talked to her and I asked her, are you having pain? She said she's okay. Nobody likes laying on an operating table, let's face it. And, but we're getting this done. Shot? Yeah. Good. I feel the herniation. Shot? It's always a little tricky whenever you're dealing with two discs, right? Because you got the two needles. Are you comfortable? Yes. All right. Did you hear that? Say it again. Yes. All right. Great. You're doing fantastic. We're going to put you to sleep in just a few minutes, all right? But I'm going to tell your story. How long have you had back pain, by the way?
3 years.
How many years? Just take a guess.
At least 7.
So give me a more accurate, you said at least 7. Give me the farthest back you remember.
2002.
All right, so 20 years. She's had back pain for 20 years. Okay, and this is typical. People suffer with back pain because they don't know how to get rid of it. And now we have a way to get rid of back pain. 20 years, folks. 20 years. Now, The back pain, when I asked her, where is your back pain? She said it's right in this area here, okay? And the only way I could possibly know that is by what's called a physical exam. And that's why you can't make decisions based on MRI alone, all right? MRI will never tell you where someone's back pain's coming from accurately, okay? What you have to do is ask the patient to point where the back pain is. She pointed here. She pointed here. And guess what's here? She had 2 discs that were herniated. Okay? That was the L4-5 and the L3-4. And I saw the herniations on the MRI. And when she pointed right there at those 2 discs, I knew the L3-4, L4-5 were the cause of her pain. But she also said she had pain over here. Right here and right here. And guess what's over here? The facet joints. So I knew before surgery in the clinic that she was going to have pain from her discs and her facets. And we had to fix both. If we just fix one, she's still going to have pain. Are you comfortable right now?
Yes.
Did you watch me do these surgeries before?
Yes, I have.
Do you know what happens next?
I get up and walk?
You get up and walk. No, not yet. Are you comfortable?
Yes.
All right. How bad is that on a scale of 1 to 10?
Just now?
Yep, the pain.
10.
10. Is that where you typically get your back pain?
Yes.
All right. Just relax. You're doing great. We're going to put you to sleep soon. So she had a 10/10 concordant at L4-5. Is it better now?
Yes.
All right. You know, you're pretty tough. Did you take pain meds today?
No.
Good. We're going to, what's that?
I said nothing.
Nothing. Good for you. All right. You have Viking blood in you?
I guess so. I got German blood in me.
You have German blood. That's just about as good. How bad is that on a scale of 1 to 10 right there?
That was a 10.
All right. Is that where you typically get your back pain?
Yes.
Okay. We're going to put you to sleep, okay? I want you to count from 1 to 100 in German. 4, 5, 6. Keep going. I want to hear it. Keep going. You're doing great. All right. While she's counting in German, I'm going to just review what we've got so far. We just tested the L3-4 and the L4-5 disc. They were 10 out of 10. And she's tough German, so she didn't yell out and cry. I would have yelled out and cried. Maybe you would have too, but she didn't. But she said it's 10 out of 10 when we tested them. Now, you're doing great. Just keep counting. What we didn't test is the facet joints, right? But we know these are painful because on exam, when I checked her out, I mashed on them and they were very tender. So I believe the L4-5, L5-S1 facet joints are also causing pain. But the discogram doesn't test for that. It only tests for disc pain. All right. Go ahead and type up questions while you're watching the surgery if you have any. Meanwhile, we're going to keep going. Shot. I think we're starting with L3-4. Place the guide wire. Take out the needle. Check. Good. Guide wire's there. Now, folks, look at this. This is called the dilator. I'm going to bring the dilator down right over this guide wire, right into her L3-4 disc. Okay? Now, I know I make this look simple, but it's not. You have to do it just right to get it right and have a good result. She okay? She's perfect for me. You can make her a little lighter if you want. Now we use a little Novocaine in the injection, the discogram, to numb up the disc so that I could do this part without causing her a lot of discomfort. And that's helping my anesthesiologist because he's not having to use as much anesthesia. Anesthesia is good, but it's also dangerous. Anytime we do anesthesia, there's a risk that the patient will go to sleep too much, stop breathing. We don't want that. So you want to keep them light enough that they're safe from a breathing standpoint, but deep enough that they're not writhing in pain. So using a local painkiller can be very helpful. And we've used local on the skin, which you saw us do. Yeah, that's good. And we used local also inside the disc with the discogram. You doing all right, Doc? Okay, everything's good. We're at L3-4. Everyone agree? And we're going to get this fixed, and then we'll do the next disc, and then we'll go to the plasma. For the plasma rhizotomy, Doc, at the end, we don't need her as deep, okay? You need help back there, or are you good? Yeah, it's got a lot of soft tissue, I understand. Alrighty. Any questions from our audience?
No current questions, but we do have a comment from Becky Musgrove on Facebook.
Hi, Becky.
And Becky said, I had a MRI last week, 5 years of bad pain, trouble walking the last 2 days, not much help yet, but meds.
No, meds don't work, Becky. Come to Deuk Spine, let us fix it for you once and for all. The problem with disc pain is that it doesn't go away. It may get better temporarily, but it never goes away on its own. It just comes and goes, and it can come back with a vengeance. And when it does, that's when people usually go get it fixed.
Lights off, please, on the...
All right, we are inside this damaged disc. You can see the material right here that I'm grabbing is all pieces of herniation. I'm going to bring in the laser at this point. The laser will do a lot of good to getting this thing fixed quickly. Thank you. Whereas the grabber just can't grab this stuff. It's very slippery and it's scarred down. A lot of people don't realize that the herniated disc is scarred in. Scarred down means it's like super glue all around the pieces, sticking it down there, and we can't get it out with a grabber. It's very slippery and it's stuck down. Everyone thinks, oh, you just need a grabber to go grab it out, but that's not the case. What I have to do is I have to laser it first to release it, because otherwise it's stuck together. And then once the laser's done doing its job, I put the grabber down and I pull out the loose pieces that have been freed up from the laser. All right, any questions?
No current questions.
Let's go ahead and show our audience exactly what is the Deuk laser disc repair procedure. We have an animation that will help you understand it.
Disc herniations are a common cause of chronic back pain. The inflamed annular tear causes back pain. Inflammation of the nerve roots causes leg pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com.
Yeah, I didn't know that. Welcome back. I'm just talking to Luis about our scopes. So now that you've watched our videos on why do herniated discs cause back pain and how the Deuk laser disc repair fixes that, what alternative surgeries are there for people that suffer with a bad disc? The answer is fusion is an option. You can have your disc cleaned out with scrapers and ground down the bones and make them angry and bloody so that they're going to want to fuse together. And then you can pack some cadaver bone, dead people's bone in there, and try to get the bones to fuse together and stop moving. By not moving, you're going to get rid of that disc pain once you clean out the disc and stop them from moving. Like any painful joint full of arthritis, inflammation, you can stop the pain in that joint by stopping the joint from moving. Another option would be to cut the joint out completely and put an artificial joint in there that's made out of metal. Because metal doesn't, metal on metal won't hurt. You won't feel it. There's the tear, by the way, the annular tear with the blue herniation. But who wants to have a metal joint put in their back? Or who wants to have a fusion of their back? They don't. This is a far better surgery than fusion and artificial discs. By the way, at Deuk Spine Institute, we've done over 1,000 fusions and artificial disc surgery in the neck and the lower back. At least I have. Most of that was done at Deuk Spine Institute. Some of it was done in my training before I got here. Look at the tear right there. You see that? You can see the white right there separating, and the blue stuff is the herniation within the tear. That blue stuff is why this won't heal, why it causes so much pain. Your body's trying to heal the tear, but it can't because the blue stuff is stuck in there. And that's what I'm cleaning out, is the blue stuff. Okay?
We have a question.
Sure.
This comes from Jim Kitterman on Facebook. And Jim asked, are you having any better luck with Medicare or Blue Cross Blue Shield?
Hi, Jim. Thanks for asking. On insurance side, Medicare, we tell all of our Medicare patients, don't expect Medicare to pay, because they won't. Medicare won't cover new technologies. Now, does that mean Medicare will never cover it? Always? The answer to that, I believe, is they will eventually cover it, but we're going to have to fight them. We as in patients and Deuk Spine together. I think there will be a day that Medicare will cover the Deuk laser disc repair, but right now they don't. And by the way, over half of our patients are Medicare patients. They just pay out of pocket for the surgery, knowing that Medicare will not cover it. Other insurances have covered the surgery, but we don't have a contract with them, so you get a good adjuster who will pay it, and then you get a lot of bad adjusters who won't pay. And the goal there is just to save money for the insurance company. Every dollar they don't pay the doctor is a dollar they keep as profit. So insurance companies love the fact we don't have a contract. As a matter of fact, they're the ones who made it that way. They don't do contracts. They try not to. You see it in the news all the time. Hospital and Blue Cross Blue Shield don't agree on pricing, so the contract is ending. It's ending because the insurance companies are trying to rip off the hospitals and doctors and not pay them. And so at the end of the term of the contract, you do what's called a renegotiation with the insurance company, hoping to get them to pay fairly. But they always come back and they want to pay you less. Well, the cost of providing health care hasn't gone down over the years, it's gone up. So we can't take less payment. We can take more payment, but not less. And so that's typically when contract negotiations between the providers like hospitals and surgery centers break down between them and the insurance company. Remember, if you can be a non-profit insurance company and still people can make a large amount of money, like millions of dollars in profits themselves running those companies. There's ways to hide the profits for companies like Blue Cross Blue Shield, United Healthcare, Cigna. They hide their profits in subsidiary companies that provide services that are not regulated in the amount of profits they can make. So the problem is, folks, health insurance business is a for-profit business. And because they're for-profit, they're going to try to keep every dollar they make. Remember, you pay them a premium every month. Let's just say you pay $1,000. If they can keep every dollar of that $1,000, then their profits at the end of the year are going to be higher than if they actually have to pay doctors and hospitals. So they do what's called denial, where they don't pay the bill. And they look for any reason they can not to pay the bill. And even when they have a contract with certain hospitals, they still won't pay the bill. So a lot of hospitals now don't have contracts with insurance companies because they don't pay the damn bill. Or they pay the bill, but they pay too little. Yeah, it's an ongoing problem. It's not unique to Deuk Spine. It's a problem all over the country and with all insurances. There's not a single insurance that actually is fair in their payment of bills. They're always trying to get out of paying the bill. I'll give you an example. Let's talk about Medicare. So what does Medicare pay an anesthesiologist for an hour's worth of work? Anybody know? Do you know? It's around 80 bucks. Let's just say 80 bucks. It varies depending on your geographical area, but it's around 80 bucks. Now, I'm going to ask my anesthesiologist, will you work for $80 an hour? He says he cannot. He's right. First of all, it would never be fair to pay an anesthesiologist 80 bucks an hour. But they can't afford to stay in business at 80 bucks an hour. So why does Medicare get away with paying them 80 bucks an hour when that's not enough money? And that certainly isn't the fair market value, is it? Fair market value is about 200 bucks an hour. Okay? So Medicare is way off. Does Medicare care? No. Medicare don't care. They say that's what we pay. Now, if you're a hospital, what they make the hospital do then is pay the other 120 bucks an hour to the anesthesiologist. So they know that they're always going to short the anesthesiologist, but that the hospitals have to do surgery to stay in business. So the hospitals will just offset the rest. It's a scam, folks, but your insurance is screwing doctors and hospitals left and right, and you guys are going to be the victims eventually because you're going to have to pay out of pocket for what they don't pay. Because we all have to stay in business to be able to provide care. Bet you didn't know about that. All right, what other questions can I answer?
This next one isn't a question, but it is seeking for advice. This comes from Etienne on Facebook. Forgive me if I pronounced that wrong.
Hello, Etienne.
And they said, Dear doctor, although my surgeon proposes the advantages of a minimally invasive neck entry, he proposes to drill a 3-millimeter hole in the vertebrae to reach the hernia. I am afraid that this would reduce the strength of the vertebrae. I would like to have your precious opinion. Thank you.
Yeah, that's really good. I like that. Thank you. You know, that sounds like one surgeon that I know. His name is Dr. Joe, and he's in Pittsburgh. He's known for drilling holes in the vertebrae to get to the disc. And I think he might even have pioneered that technology. It's called the Joe procedure, spelled J-H-O. I don't think drilling a hole in the vertebrae itself is going to cause instability. But what I know about the procedure, if it's who I think it is that he doesn't stop at the vertebral body. He drills a hole in the joint. It's called the uncinate joint, spelled U-N-C-I-N-A-T-E, joint on the side of the vertebrae. And that will destabilize the cervical spine. How do I know? Well, number one, I'm familiar with his technique. Number two, I've seen patients that have had that surgery done, and they're unstable. So he definitely created instability. And they're his patients, by the way. They had the surgery done with his technique by him. So I'm aware of the technique. I don't think it's a good technique. I would do the Deuk laser disc repair. It's a far better procedure. You don't want the drilling of bone, ever. There's no reason to remove bone from your spine, except that the surgeon needs to do it to get to the herniation. And the Deuk laser disc repair technique doesn't drill any bone away. It keeps your natural bone there, which you want. All right, my patient is awake. How you feeling? You're doing great, by the way. We're done with one disc. We're going to get started on the next one, okay? All right, she may be back asleep. She just woke up momentarily. But great question about that procedure, which I believe you're talking about is the Joe procedure. Once again, I don't recommend it. I can perform that procedure myself, but I don't perform it because I think it's not a good procedure. I've been able to decompress the nerve roots in the neural foramen in the cervical spine every single time I've done the Deuk laser disc repair, and I don't remove any bone from your spine. So it's possible to do it. There's just a better way to do it. There's a lot of bad ways to do spine surgery, in case you guys haven't figured that out. At the Deuk Spine Institute, we know how to do all the bad ways, but we also know how to do the best ways, and other doctors don't know how to do the best ways. So we're able to choose between the bad way, the bad surgeries, and the best surgery, and we always try to choose the best surgery. But you have to have the right equipment and training to be able to do those kind of best surgeries. And it turns out that best surgery is the Deuk laser disc repair. The reason I'm struggling to get the dilator on there is because she's breathing up and down, so it's kind of moving it. But I like challenges. Luis knows that. He knows better than to try to help me. He also knows I get it eventually, right?
Yeah, of course.
All right, a little pressure here.
Yes, sir.
So we're finished treating the L3-4 disc, and we're now going to be moving on to the L4-5. She's doing amazing. She's so helpful. Laying still. This is the more stimulating part. Yep. So as we enter the disc with the dilator, this is going to be the more stimulating shot. Yep, that's good. Take that. Let me feel it. Feels good. Go ahead. All right, I need to go in just a little bit further. Shot. You're doing great. I don't know if she's awake or not, but I'm encouraging her, letting her know everything's okay. The last thing you want to do as a patient is to worry that something's wrong. She doing all right?
Yeah.
You want me to wait or shall I proceed?
Doing okay, man?
So go ahead. This might be a little uncomfortable. Huh? Yeah. All right, so we're going to give it just a minute for our anesthesiologist to give her a little more medicine. You're doing great, by the way. Everything's going well. As I was saying earlier, when you don't have a patient with a tube down their throat on a ventilator, you're giving IV sedation, and your goal is to keep the patient comfortable, which she is comfortable, but she's kind of on the edge. She could start feeling things right now, so we want to give her a little more sedation. All right, this would be a good time to ask questions. All right, we're going to move forward. Our anesthesiologist has given us the green light. Shot? Yep, let's take that out. Luis with the hands of steel. Hold on. Let's get a wet. Oh, you got it? All right. You've heard of the man of steel. We've got the hands of steel right here. Sometimes you got to be cheesy in the operating room. You know? So far, everything is going very well for this nice lady. Very excited for her to get out of pain. Yep, thank you. All right, you can see we have a tiny 1/4-inch incision. We're going to go in with the endoscope next to the next disc we're fixing, which is the L4-5. You can already see the disc right there. That's the herniation stuck in the tear. There's a lot of inflammatory tissue around it, the pink stuff. This is where the pain's coming from. So I'm going to try to pull out any pieces of herniation I can. Because remember, I just went in through the herniation, so we really shoved the pieces of herniation back into her disc. By the way, that's a much safer way to remove herniated pieces of disc is inside the disc rather than outside. Outside the disc, you're talking about possibly injuring the nerve if you're grabbing with these metal grabbers in the foramen. So it's better to always remove herniations from inside the disc rather than outside.
We have a question.
Yeah.
This comes from Justice on YouTube.
Hi, Justice. Switching irrigation? All right. Thanks.
And
Yes, Justice.
They asked, why do you keep your patients awake during the procedure? And with someone with multiple failed procedures and has PTSD and severe anxiety, would you keep said patient asleep during the whole procedure?
Yeah, great question, Justice. So the answer is our patients really aren't awake, okay? They are sedated, but the amount of sedation they have on board fluctuates throughout the surgery, and that's normal for that to happen. It happens in every non-general anesthesia case, this is a non-general anesthesia case. So it's normal for the patient's mental status and level of sedation to fluctuate up and down, deeper and lighter throughout the surgery. She's not going to remember anything because part of anesthesia is something called amnesia, and amnesia is where you don't remember anything. So yeah, there's no conscious awareness of what's going on by the patient. But we talk to the patient sometimes as if they are, just because in case they happen to be a little too light, they hear a nice voice instructing them that everything's okay. So that's why we do it that way. We don't expect her to be awake. Our patients are asleep, but they're just at different depths. Now, when you're asleep, it's normal for you to move your body around, right? I mean, everyone that sleeps moves in bed. Some people move more than others, and some of our patients, while they're asleep, will move a little bit. That doesn't mean they're awake. It just means they're moving. And movement is something that's completely independent of being awake or asleep, okay? Lots of people that are asleep move. As a matter of fact, there are people that sleepwalk. So they do a lot of movement when they're asleep, totally unaware of what's going on. The key is we want our patients to be safe, but we also don't want them to remember the surgery, and that's the goals we achieve, is sedation and amnesia. Now, the not having pain part we also work on, and that's called analgesia. Analgesia means get rid of the pain. We do that through medications that we either inject in the vein, like fentanyl, or medications that we inject under the skin or in the disc. So the three parts of anesthesia is to be asleep, or sedated, to not feel pain, which is analgesia, and to not remember the surgery, which is amnesia. Those are the three goals of all anesthesia, and we achieve those goals here. Great question. All right. Did you learn anything there, Henry?
I believe so, yeah.
All right, good. Grabber?
We don't have any new questions, but we do have a couple comments.
Sure.
Justice replied, pretty much said that he is your new patient.
He is what?
Justice, pretty much, who's the person who asked about the sedation and all, he just said he's your new patient.
All right.
And then a comment from Becky Musgrove on Facebook. She said, I have the bulging and herniation and arthritis, terrible hip pain and numbness in my left leg, also the same going on my neck.
Yeah, Becky, it sounds like you got herniated disc in your neck and lower back. We can definitely help you. All right, take a look at this. See the blue streak goes up and down? That is the herniated disc stuck within the annular tear. And that's what we're here to treat, okay? Again, the Deuk laser disc repair is the only surgery that does this. There's no other surgery in the world that does a debridement endoscopic of the annular tear, or any debridement of the annular tear. So we're going to finish this disc, debridement, and then we're going to move on to the facets. So if you've got questions, I recommend asking them now. We're not going to do a post-operative question and answer. We won't be able to on this case. But we'll be back for our next case later this afternoon if you want to join us. I apologize for the poor visibility. It's not great for me either. What you're seeing is a little bit of red blood cells basically within the liquid. Is our irrigation good?
Yes.
All right. Laser standby. See if I can make it better by placing the grabber down there. Again, I'm pulling out pieces of herniation that are being freed up by the laser. Let's go ahead and show our audience. You've already shown them why the herniated disc cause pain, right?
Back pain and the TLDR, yes.
Yep. You have any other videos they can watch?
Oh, for the lumbar comparison, yep.
Yeah, why don't we do that in a few minutes?
Copy that.
Because I'm just about done here. And then we're going to wrap this up and move on to our Deuk plasma rhizotomy for the facet joint pain. But let's take any questions the audience might have at this point.
No current questions, but we do have a comment from Justice on YouTube, and he said, I'm waiting for you to review MRI from September 23rd of this year. I sent the CD disc by mail yesterday evening, waiting for the phone call visit.
Fantastic, Justice. Looking forward to helping you get some answers and hopefully fixing you. Yeah, Sam is the custodian for the MRI reviews. She is going to be reaching out to you once we receive your MRI. And Sam is really good, so I expect her to be in touch with you shortly.
We have another question.
Sure.
This comes from Assad on YouTube.
Hello, Assad. Welcome to our stream.
And they said, hello, Doc. Do the collapsed discs regain their shock-absorbing properties after the healing period of 1 year?
Hi. No, the discs never regain their full fill of jelly with any surgery. And that's not an important function, believe it or not. A lot of people believe mistakenly that the jelly's purpose is a shock absorbing, but it's not. The purpose of the disc is to hide the jelly from your inflammatory system. You see, the jelly is actually an embryological remnant of the notochord, and it's very, very inflammatory, very painful if it gets exposed to your blood supply. So the disc itself in the center where the jelly is has no blood supply, and it's by design. Basically, evolutionarily, we've evolved to where the people with the jelly tucked away in the middle of their disc don't have pain, and they're able to function normally, take care of themselves, provide food and mobility, get around. And the people with weak discs, where they rupture and let the jelly out and have horrible pain, unfortunately they end up being very reliant on their family members or friends socially to care for them. So the reality is that the jelly in the center of the disc is not so much of a shock absorber as it is just hidden away, not causing problems for people. Let me get this little piece right here and we'll be done. So I was taught that the jelly is a shock absorber as well, but the reality is it's just a way of putting away a very painful tissue, hiding it from your inflammatory system. If that makes sense.
We have another question.
Sure.
This comes from Justice, once more on YouTube.
All right.
And they asked, after removing all tissue, does the remaining disc heal itself?
Yeah. So Justice, we're not removing all the tissue. We're literally fixing 5% of the disc is what you're seeing here. The other 95% we're not touching because it doesn't need to be touched. Only this small corner of your disc is where all the pain comes from. There's one on the right, one on the left at every disc in the back. So we're only treating about 5% of the disc by volume. So hopefully that helps you understand. We're not taking out the disc. We're only taking out the herniation and cleaning the tear from whence it came. If you can clean the tear and let it heal, then no more herniations will happen in the future. And the pain goes away permanently. All right, we're done here.
Lights on, please.
We're done with the broadcast. We're going to show you what this patient would have to do if they didn't have the Deuk laser disc repair. And that would be basically a decompression infusion surgery. It's much more invasive. So take a look at this video and we'll see you in about 45 minutes for the next surgery.
Deuk laser disc repair, a comparison with traditional spinal fusion surgery. A patient with chronic back or neck pain originating from a symptomatic disc injury could undergo either traditional spinal fusion or less invasive Deuk laser disc repair. This MRI represents a typical case with L4-5 and L5-S1 symptomatic discs. A symptomatic disc causing neck or back pain can include bulging discs, herniated discs, ruptured discs, degenerative discs, protruding discs, spinal stenosis, radiculopathy, and sciatica. This patient can choose traditional fusion surgery or the Deuk laser disc repair to help alleviate the pain caused by and within the symptomatic discs. Here, two patients with comparable disc injuries are treated. On the left, the highly invasive spinal fusion, and on the right, the least invasive Deuk laser disc repair. The spinal fusion requires a very large incision, usually leaving a large scar. The Deuk laser disc repair requires only a very small incision, usually less than a half an inch long. In this small opening, a cylindrical rod, called a dilator, is inserted to gently spread the muscle to create a small passage and guide through which the surgery is performed endoscopically. The incision for the fusion continues, including penetrating the skin, fat tissue, and multiple layers of muscle through to the bone. With the Deuk laser disc repair, a mallet is used to advance the tip of the dilator into the symptomatic disc. A tube, called the tubular retractor, slides over the dilator and is carefully positioned into the disc, again using the mallet. The rest of the entire Deuk laser disc repair surgery will occur inside this narrow tube. To access the spine, the spinal fusion requires the muscle to be separated from the vertebrae. This very invasive action causes trauma and permanent damage to the muscles. Whereas in the endoscopic Deuk laser disc repair, the muscle is not damaged. The endoscope camera is inserted into the tubular retractor to allow the surgeon to guide the laser inside each symptomatic disc. To accommodate the fusion hardware, a large bone grabber is used to perform a laminectomy by removing bone from the spine. The fiber optic laser used in the Deuk laser disc repair is manipulated with great accuracy to remove only painful inflammatory tissue from the disc. In this highly magnified view, the laser is used to precisely remove damaged disc material that is causing the pain. The laser is debriding, or essentially vaporizing, damaged tissue in the disc's outer layer, or annulus, specifically at the annular tear, the source of the rupture or herniation and pain. After the fusion patient's damaged discs are removed, a metal or plastic cage housing bone grafting material is inserted in place of the removed discs. Once the laser has removed the painful part of the annular tear, the endoscope and tubular retractor are removed, leaving less than 1/2 inch incision in the skin, which is closed with a single stitch, Steri-strips, and a Band-Aid. Total time for the Deuk laser disc repair surgery, approximately 1 hour. The fusion, however, is still underway. Holes in the spine must be tapped in preparation for the large pedicle screws that anchor the fusion hardware. The Deuk laser disc repair patient is in recovery usually 45 to 60 minutes before released to go home. The fusion screws are inserted into the bone, as shown in the X-ray. After all screws are in place, rods are used to connect the screws together to prevent movement of the secured vertebrae. Cross-links are added to bridge the rods together for additional stability. Fusion hardware, by design, is to fuse joints that normally move, preventing natural movement in the damaged portion of the spine. Whereas with the Deuk laser disc repair, there is no loss of movement. Normal movement